Hey, Vlad.
John, hello.
How you doing?
I'm fine. What about you?
Yeah, you're early.
Yeah. What is your weather there?
Well,
You
it's beautiful. It's beautiful. It's it's a little. It's a hold on. Let me get a little. I got some. Hold on. Hold on, Vlad. I got the. I had the two microphones on.
I see.
A common mistake.
Right.
But yeah, it's getting a little cooler now.
Yeah.
Around
No,
this time.
someone's knocking on the door. I will leave you for a while.
Oh, okay, coming back. Okay. Yes, someone has a hand raised. Okay. Hello, so you have your hand raised. Hello. I'll let you guys watch. Uh, Did someone want to say something? Someone has their hand raised. Do you want to speak to me directly? You have your hand raised. Do you want to? Okay, I'll lower it if you don't want to speak. Mhm. Hey, Juha, did you get in okay?
Hello, John. Hello,
How you,
Vlad.
how you doing, Juha?
We seldom had so many technical difficulties and to arrange this webinar, but I think now we are doing well.
Oh, okay, yeah,
So-
it looks fine. Yeah, Vlad's here.
I will speak short introduction for Vlad Benes, and
Yeah,
then
sure.
but I planned I can do also next Friday. I can do
Oh, great. Well, Juha, whatever you
more
want.
webinar alone. So I will
Okay.
tell about my Chinese experience.
Oh, that would be great. If you want to make it
Hello,
two
John.
parts, that's fine. Hey, Ben, welcome.
Hi.
Well,
Hi. Would you
be-
please send me the Zoom number for this conference because we couldn't log on with the computer. I
Really?
don't know why.
Oh, okay, I'll send it again. Okay, hold on.
Okay.
Hold on.
Not the link directly. We
You
need
want me
the
to
Zoom
put
number.
it in the chat
Who is that?
or in email?
Mhm.
Hmm? Somebody in the company. That's his profile. That's his profile. Which I use.
Okay, Ben, I'm putting it in the chat. Okay. Oh, wait a minute. Chat, right.
Okay.
This one is my
Oh, that's no, that's not it. That's not it.
like
No.
wrong name, but I hope
Oh, man.
this is take that. This is very good now. I put down that.
There's a Zoom I just put in, Ben. I'll email it to you too, okay?
Can you manage now, Subin?
Yeah, okay. I sent it.
Yes. Now it's
Yeah.
okay.
Yeah, okay. I sent it through email too, as well as
And
the panel.
everything okay for Vladimir Benes?
Yeah, Vlad was here, briefly
Okay.
stepped away.
Okay, went to operation room or somewhere.
I've got Vinko. Vinko's speaking in Seattle on next week.
Vinko, yeah?
Yeah,
This
yeah.
one I want to see.
Yeah, he's the 11th. I'll send you an invitation and everything.
That's good.
I think you spoke in front of them, Seattle Foundation. I think you spoke there. And Ben just spoke there last week.
Yeah.
Yeah, this is Finnish international star,
Yeah,
world champion in bypass.
this platform's made for him.
Yeah, this is he's
Thank you.
extremely famous now around the world.
Yeah, we'll talk
For-
later, Ben.
In
about-
international neurosurgery, certainly the most famous Chinese neurosurgeon.
Well, I'll talk to Ben later about what we want to do and what we can do, you know. But if you want to take more than one part for next week, that's fine.
I will take on Friday. I will take on this. I will make Juha's grand rounds myself totally.
Okay.
It's the last one for some time.
Yeah, your experience in China, that would be good.
Yeah. This is I have given it 3 times this lecture, and now I can improve.
Good.
Now I can improve, and I will concentrate heavily on that.
Okay.
Like Richard Asti was always saying that this might be interesting for you. When we went to a restaurant and he wanted I should try something, this might be interesting for you. So also the webinars might be interesting. I don't see many people here now.
Yeah. Okay, hold on. Let me let them in.
We have some time, 5 minutes.
Yeah. People tend to come late at the last minute.
There was a time change in Europe.
Oh, really? It's different?
Yeah, they changed the time.
Yeah, it gets tricky. South America.
This is nonsense. This is nonsense. I
I
think
know.
it is nonsense
Yeah.
because at least neurosurgeons are so used to be awake and work in the night. So to change 1 hour is nothing. So it's just confusing.
It is. First, you go over time zone in South America, it's really tricky. It's like 3 different time zones.
Hello,
Vlad.
Hello,
Hi.
Vlad. Welcome.
How are you?
I'm okay. I'm okay.
Very
I'm
good.
okay. I'm very
Very good.
glad that we could arrange those
Hello, Professor Bennett.
technical difficulties
Hello.
because
Ben, hello.
Hi.
Hi. It's confusing with the time. The difference is different now that we have the winter time, and it's confusing only.
Oh, yeah.
this is nonsense. Like I told you that neurosurgeons are so used to be awake in aqua time, so 1 hour change doesn't mean anything in our life.
I like the summertime because you can play tennis long into the night because it's still some daylight.
Mhm.
But they want to quit it. They want to quit
In
these
Finland,
changes.
it's not the problem.
It's not.
In Finland, it's not the problem because it's all the time.
Of course,
Right.
you do not have any dark during the summertime. We do.
there's- Sun is not going
And
down.
then now it's terrible because you get up in the dark, you go home in the dark, and it's raining. The weather is terrible here.
It's the winter time.
Cold. Yeah, the worst
It's
time
the
of the
winter
year.
time.
Come on, you guys. It doesn't matter what it's like outside the hospital. You spend your life in the hospital.
That's true.
It's the weather inside the hospital that
Yeah.
counts.
John, this is the
Triangle.
time when you do not want to go out. You just stay at the hospital or at home and nothing more.
Yeah, you guys.
They
Worst
call
time
it
of
Bermuda
worst time
Triangle.
of the year.
Bermuda Triangle.
Nah.
Hospital, home, and some shopping. These
Right.
are the 3 things you are doing.
So you are going back to Finland?
Now, November 17th, I will go.
November
But I made a partial agreement here in China, so I will come 4 months a year, 2 times. 2 times a year. So we will
Good for
then
you.
continue. this is good agreement for me because it is
Right.
I can slow down.
And Finland, is it Helsinki or home, or are you from elsewhere?
I have been now. My home has been in China, but I have a home in Helsinki also. So
In Helsinki.
I'm ready to go.
Oh, you're going to spend
flat-
part of the year there in Helsinki?
Hmm?
You're going to spend part of the year in Helsinki?
Yeah, of course, of
Oh.
course,
Okay.
of course. I was thinking, yeah, it is good to go home after 5 or 6 years.
Of
Yeah,
course.
it's been a while.
Of course. It's a long time.
Yeah, it has been very hard time now in China because of the COVID time, because the restrictions are here extremely strong. So you are not allowed to travel outside of the city. So I have not been traveling. Last time we met in Prague. After that, I have never been elsewhere.
Never again?
No, because it is forbidden to travel.
So you are either home or in the hospital, nothing else?
Nothing else.
Ooh, must be hard.
Yeah, it has been hard, but I could do some good work. I could write my memories, so they will come out in spring.
Good.
Yeah.
Like a book, you mean?
Yeah,
Yeah, great.
500 pages. I was in quarantine 6 weeks, total quarantine, so I began to write and was doing well.
And did you have COVID or not?
Hmm?
Did you have the disease or not?
No, I have
No.
no. In China, you have 100 cases a day, and then they are terrified.
500?
100 cases.
100.
It is
It's nothing.
1,410
Imagine that in all
million
of China.
people.
Wow.
We now
all
have
China.
9,000 a day.
No, 100 cases here.
Okay, gentlemen, ready to start?
Ready?
We are ready to start.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. It's Dr. John Bennett broadcasting from Miami Beach. In the background, we have the pleasure of having Vlad Bennett, he's neurosurgeon from, I called it Czechoslovakia, but I was wrong. It's the Czech Republic. And I'd like to introduce Juha to give a proper neurosurgical introduction to Vlad. Welcome. Good morning, Juha.
Thank you. Welcome, everybody. So, go to the beginning. Can you see now?
Yes.
Okay. So, I welcome my good friend, Vladimir Benes, to give this webinar. He's coming from Prague, Czech Republic, like we discussing. He's one of the most important and well-known neurosurgeon of these times in the world. He was born 1953 in Prague and then went to Masaryk University for neurosurgical and surgical training, if I understood right. And he made both surgery and neurosurgery 10 years, 1978, 1987. And as young man, he became leader of the clinic and chairman and full professor since 1997 and 2002 also in interventional and endovascular surgery. So he has very wide spectrum of skills. So I always saw this slides, how to become a good neurosurgeon. I never met a person who wanted to be a poor level neurosurgeon. So I recommend train hard, and I know Professor Vladimir Benes well, so you should follow the way he has done, and he's certainly telling in his presentation. In neurosurgery, there are levels of manual skills, and the manual skills are coming from number of repetitions and length of career. As the old old rule of 10,000 hours of training, you can come to the world top. My rule is that after 10,000 days in operation room, you are at your best. So neurosurgery has different parts: operative skills, research, clinical and basic. Professor Vladimir has trained high number of residents and fellows and visiting other clinics around the world, teaching all around the world. So I call it also going around. It's very important. I call it stealing the experience. I have been sitting more than 3 years in cold corners of the operation room and stole the tricks. He has been involved in big number of important publications, participate in extremely many congresses. I think we have met in several continents, several times, India, Japan, Nepal, and he has given now many webinars and is involved in many life courses. So this is what I think about Vlad. Great leaders don't tell you what to do, they show you how it is done, and he's doing that way. He's a great man. He's pioneer in many new treatments. He has huge number of international connections and has been very important leader in different societies like European Association of Neurosurgery, president of the Meningeal Society, and many other positions. His father and son are also neurosurgeons.
Vladimir 教授一家3代都是神经外科医生，他的父亲和他的儿子都是神经外科医生。他的父亲呢最近去世了，那是享年100岁。
Vladmir's father and son are also neurosurgeons. So the 3 generations, I think it is extremely rare in the world. I don't know many of them. Father and son is rather usual, but 3 generations extremely rare. Vlad has certainly good genes because his father died recently at the age of 100 years, so he can continue many things in neurosurgery, but also other activities of life. So you should train your best young people. Vlad is certainly doing that, and they are always getting better than we, older generation. I welcome Vladimir Benes, Professor Vladimir Benes, to speak on supracerebellar infratentorial approach is one of his very good specialties. So welcome, Vlad. Thank you.
Juha, thanks for great introduction. Let me share the screen. No, this is not the one. Can I share again? You share, because it's the lecture is here. Just now? Yes, that's it. That's correct. Do you see it well?
Now it's okay.
It's okay. Juha, thanks for the introduction and thanks for the general thoughts, which you always have excellent and very important. I believe that probably the most important part of the introduction was that the pupils must be better than the teachers. Otherwise, the teacher is not good. And I always tried to grow better neurosurgeons than I am, and I hope that I succeeded at least sometimes. You were talking about Nepal. Here we are together sitting in Nepal, and we obviously are discussing supracerebral infratentorial approach because I know well that you love the approaches the same way as I do. That's my favorite approach. So let me talk about it and let me share my experience with this approach with all of you. Over the past 15 years, I have used it in 174 cases, and you see that the mother of all, or the first, were pioneer cysts, which are very specific topic and very hard center of discussions, whether they really are neurosurgical disease or not. I hope that they are. On the other hand, the majority of my cases were meningiomas of petroclival region and CP angle. And then it went a little down, but there's a plethora of lesions which you can really approach by this very simple approach. I call it pterional of posterior fossa. And I just will now share with you the specific cases which I have, where I use this approach. Not all these cases are for surgery. See here, this pioneer cyst, a large one, you would say, all right, this is for surgery. This is half a year later, and a year later, you do not see anything. So one must not be really fast. One must be very careful and, let's say, thoughtful in decision making. The most important landmark for this approach is the vein of Galen. As soon as the lesion is above the vein of Galen, like this colloid cyst, you come from above. As long as the lesion is below the vein of Galen, the supra-infra approach is the best way. So the modal disease is pioneer cyst, and the best training disease for this approach is fifth nerve decompression. We use this approach for microvascular decompression almost always, because you excellently see the whole length of the fifth nerve by this approach, and you do not stretch the nerve the same way as you do in retrosig. You just push it from up and down, and it's, in my mind, more gentle than the retrosig. So this is the best training how to approach this region. And this is the beautiful anatomy of pioneer region. This is Roton. This is our surgical view. You see both Rosenthal vein, internal veins, vein of Galen, and all the structures in the vicinity. I mentioned the pioneers. We have published quite a lot of them, starting with the worldwide online survey, going to radiography, going to natural course. And now we ended up with new technique of resecting these cysts. We are keeping the anterior inferior part of the cyst wall behind, just to keep the patient his own melatonin secretion. We do not know whether it works. We do not have results yet, but we are at this point, and that probably will be the last study on pioneer cysts from our hands. So how we do it lately? Over the past year, it's unilateral only. There was one exception, one case I did from bilateral. It's sitting position. We are not afraid of sitting positions. We have good anesthesiologists, good monitoring, and it's not a problem for us. I'm not saying that we didn't have any air embolism, but our anesthesiologists are able to manage. I use some CSF drainage at the beginning of surgery, almost exclusively lumbar drain, because I do not open the skull as far as cisterna magna, which would be obvious place. I don't like ventricular catheter, so lumbar drain. And it's only for the very beginning. You start with your cerebellum already being fallen down from the tentorium. If you don't use the CSF drain, you may end up with cerebellum still coming to your way, and to get to the systems, ambient system first during this approach this time. So we drain some CSF at the beginning. Craniotomy goes well above the transverse sinus. Dura is U-shaped open, but only 15-20 millimeters below the transverse sinus. If the opening is too generous, then the cerebral hemisphere tends to prolapse through the opening, and that may cause problems. So the opening is very modest as well. Several stitches, of course, to lift the sinus, and we incise the tentorium, as you will see, as needed. These are the positions with microscope and exoscope. It's rather ergonomic. Only the short arm neurosurgeons cannot do this with microscope. They would have to use the exoscope. And the exoscope is an excellent instrument for this. The only problem is that we all are accustomed to vertical axis movement, not to the horizontal. So the most important role of the assisting surgeon is to push my hands into the wound. Then it's without any problem. So this is the craniotomy. You see the transverse sinus. This is after the opening and some drainage of the CSF, and you see that the space is already open, and this is the space you achieve going to the pineal region. But it's not only pineal region for which this approach is suitable. We have medial approaches and lateral approaches. For medial, we can go anterior, which is direct vision. It's pineal and posterior third ventricle. Anterior superior, which would be posterior thalamus, and anterior inferior, which would be quadrigeminal plate and upper fourth. So you approach all structures around the pineal gland. And the lateral approach above the cerebral hemisphere, it's again lateral anterior, it's directly to the T-close apex. Lateral superior, it's upper temporal edge. And then lateral inferior, when we reach the pons. And I will show you examples of each. And then there is the third avenue, which is superior. It's medial, temporal, and occipital areas by cutting the dendrium and going through. It was all described in this article, which we have published quite recently. Okay, so medial anterior, directly to the lesion. And this is the pineal cyst. The arachnoid in this region is always very dense and very, very hard. So you cannot open it by tearing. You always should open it by cutting and by sharp instruments. And you must be oriented yourself about the veins. The veins are important. So here we have the internal cerebral vein. This is Rosenthal vein. The same way here. This is the Rosenthal vein, and this is the internal cerebral vein. And here, at the apex of the cerebellum is one single small vein which should be preserved. It's a cerebellomesencephalic vein. Fortunately, this vein usually is shifted to the side so you can preserve it and still get the proper approach to the whole area. And once you release the cerebellum, you get enough space for any maneuvers in the pineal region, and everything's done sharp. As you see, don't tear, just cut. Be sure that you do not tear anything, because you could tear the one of the veins, which would be a disaster. And now we can see that pontomesencephalic vein, probably, or most likely, and we are directly on the pineal gland, which is then resected. Here in the back is the pontomesencephalic vein, behind the scissors, this one. And let's get to the pineal gland. Now it's enough. And this is cutting of the pineal gland along with the whole gland, which we are not doing anymore. We are keeping a little piece behind for the melatonin secretion. And what you look at is the third ventricle, which is very generously open. This is the interthalamic adhesion, the white structure at the bottom, and the whole gland is released and resected. We didn't see any consequences as to hormonal production, but still we just recently tried to preserve the patient's own. This is the pontomesencephalic vein. And here we are looking into the third ventricle, which is beautifully opened, and all the posterior and upper third ventricle regions can be accessed with this approach. It's about the two systems, which is quadrigeminal and pericallosal, and of course this system forms some arachnoid, which is around the vein of Galen and around the basal veins. So you can keep within this arachnoid space and do not traverse anywhere else with the pineal gland. And here are the tumors. This is ependymoma of the posterior third ventricle before and after resection. Here is the germinoma, which are not that frequent, and all the tests were negated. So we went for surgery. So we resected germinoma without any trouble. Here are post-op images with the meningioma, which is solely in the quadrigeminal system. It has no attachment to the gyrus rectus or dura anywhere. Very straightforward surgery. Another more difficult meningioma, which is going forward, pushing the corpus callosum in front of itself. Still, it can be easily reached via supra-infra. This is the peanut tumor before and after surgery, again reaching the third ventricle, which you reach easily. This is anaplastic lymphoma. We didn't know that we are operating on lymphoma, of course. Here it's after then the patient went for regular treatment. This is the grade 2 pineal tumor, which is located very anteriorly, reaching the third ventricle, again before and after. This is the immature pineal tumor. This was one of the more difficult ones. And this is the space we are reaching with supra-infra. In general, it's about the systems, especially in the petroclival area. Reach ambient cistern, both its lower part and upper part, quadrigeminal cistern, pleural cistern, and interpennicular cistern. And in front of this, there is the border which you do not transgress, which is the Lillienquist membrane. This is the true division of the posterior fossa. And you see on this beautiful image from Pablo González Lopez, these things readily accessible through the supra-infra approach. It's direct way, direct avenue. We also shouldn't forget velum interpositum, which some of the meningiomas grow in also. So medial anterior superior now approach, which is for the fissure between the mesencephalon and the temporal lobe, where the posterior cerebral and superior cerebral arteries are located, which is actually ambient cistern. And you see this for thalamic lesions, this excellent approach. You see this pilocytic astrocytoma within the thalamus, and here is the surgery. We, of course, use navigation for this, but since you move the structures, it's not that easy. We saw that we are not high enough, so the tentorium is cut and opened to reach another few millimeters higher up. And this is the point of the thalamus where the cyst is just under the surface. And this approach allows you the direct and straight avenue through the cyst to the tumor. So this is the opening of the thalamus. The cut is vertical, and you are directly on the tumor, which is resected in a usual way, no problem. In this is the tumor cavity after the surgery. Here are the post-op images. You see where we were. Actually, here was the tumor located. Now it's completely tumor-free. It was pilocytic astrocytoma, and this is the patient who is completely free of any neurological deficit, being just happy. Another pilocytic astrocytoma in the thalamus, again resected by the supra-infra approach radically. The cavernoma, which are probably rather frequent lesions which we operate by this approach, again, is in the fissure between the mesencephalon and temporal lobe. We are in the ambient cistern. This is the opening. This is just to demonstrate that we do not open dura too low. We open the dura parallel to the transverse sinus, some 15 millimeters below the sinus. This is the opening. You see that it's very modest. You do not need to open and push the cerebellum that much low. It's again cutting the tentorium, and you will get the internal cerebral vein, which is internal occipital vein, which is here. This is one of the branches of the posterior cerebral artery, yellowish tissue on the surface, so it gives you the approach, and then the cavernoma is resected in a usual way. At the end, it's sufficient corridor to insert endoscope to check the cavity, whether the cavernoma was resected completely. This was a happy one when it went out in one piece without any need for crushing the cavernoma or resecting in parts. So it was a rather easy one. And now we shall see the opening in the posterior thalamus where we went in, which was between the vessels. It's over here, just above the branch of the posterior cerebral artery. And this is after surgery. Again, you see the space where we were. This is immediate post-op, still with some fossil in the cavity. And this is half a year later. The patient had a transient hemihypesthesia, which disappeared within 2 months. We've published these cavernomas of these regions in 2 articles. And this was one of the more difficult cases. This is the meningioma, which is very irregular in shape, with some spaces in between, with a lobule to the right temporal region. And this is where the tumor reaches the velum interpositum. It grows along the cisterns, and you see that the tumor reached as far as that. So where we are in the quadrigeminal cistern and in the upper ambient cistern and in the velum interpositum. Again, it is the same approach. This is the lobule on the right side, opening of the tentorium to reach the subtemporal part of the tumor, which is located just over here. This is already temporal lobe. This is a little technical trick that you can put a stick directly to the tentorium and draw it up. It gives you another 2 or 3 millimeters of space, which may be important, and you have much better maneuverability by this stitch, which allows you to see a little more. So this is the lobule under the right temporal lobe. Once you resect this lobule, we shall end up a little deeper and a little more anterior. Fortunately, the tumor was rather soft. The whitish tissue at the back is the corpus callosum. The tumor is pushed down and small being resected, respecting all the arachnoid membranes. This is actually the piece of the tumor which is in velum interpositum. So this is the arachnoid of velum interpositum, and this is the anterior wall of quadrigeminal cistern, the arachnoid plane on the tumor. And if you respect it, you get the vessels. And in this case, all the vessels were very, very intimately connected to the tumor you see here. So we were able to preserve them. Then underneath the tumor, you expose the quadrigeminal plate, where usually is not a big deal with meningioma. They do not grow too aggressively against the brain tissue here. And you still have the arachnoid plane of the quadrigeminal cistern at your disposal. Here is the opening into the third ventricle. Here are the vessels, and this is the tumor remaining on the left side, which was much more difficult than on the right, because here the vessels were really very adherent to the tumor, and this is the region where no vessel should be sacrificed. You see all these tiny perforators should be preserved and dissected free of the tumor. And you see the amount of space which supra-infra approach gives you in the pineal region. It's really incredibly wide space, and the maneuverability is extremely good because the length of the corridor is rather long. This is the left, and these are the 2 internal cerebral veins and opening into the third ventricle. All right, this is after, and you see the approach, you see the corridor, and the deeper you are, the wider is your area of maneuver. So this is very comfortable for surgery. Another meningioma which is in the region before and after surgery. It's good to know about the transverse sinuses, what they look like, and in this case, the left side transverse sinus is hypoplastic, so we came in from the left side. If you want to go inferiorly, it means quadrigeminal plate. Here is the AVM in the quadrigeminal plate, which bled. Our endovascular people refused to embolize it because of this artery, which looks like an passage. I don't like radiosurgery for brain stem, so we came in surgically and we oriented ourselves only according to this atypical vein. Somewhere here is the AVM, but you cannot recognize which arteries are perforators, which arteries are going to the AVM. So we just simply went all along the vein, cutting all the vessels which entered the vein. And this tiny artery actually doesn't belong to the AVM. It's perforated. This is at the end, coagulating the vein. And let's see the post-op angio. There is no, the resection was really radical, and the patient didn't even have a transient diplopia, which one would expect. Cavernomas of the mesencephalon are excellent target for this approach. You can get as low as the fourth nerve is exiting the brainstem. This is after surgery, and that's it. Actually, supra-infra is a good approach for upper fourth ventricle as well. You can get that by Tovel, of course, but in this case, I opted for direct approach with some short paravirmian section of the cerebellum. Here we are already on the lesion. Here there are 3 atypical veins which definitely were preserved. And this is after surgery, and you see the shortcut in the cerebellum with no consequences, of course, and the resected cavernoma. Pineoblastoma in the region, you can get again into the fourth ventricle for this part of the lesion via the supracerebral approach. Let's go to the lateral side, and those are mainly meningiomas, and let me show these 2 meningiomas because I want to stress the importance of arachnoid plane. We have 2 olfactory groove meningiomas which are identical in volume. The difference is that in this case you have the edema only unilateral. In this case the edema is bilateral. In this case the anterior cerebral arteries are shifted to the opposite side. In this case, the anterior cerebral arteries are in the midline. What does it mean? It means that on the opposite side, on the left side in this case, the frontal lobe, as well as olfactory nerves, is covered by 3 arachnoid planes, which gives you plenty of space for dissection and preserving the structures. On the other hand, in this case, both frontal lobes and both olfactory nerves are covered by 1 single layer of arachnoid only. That means that in this case, you should preserve the olfactory nerve function, and we achieved that in more than 80% of patients, which was in this publication, and of them, some 50–80% got some feeling. In 50% of cases, there was normosmia, hyposmia in another 30%, which is rather important. Same applies for tuberculum cellae, which was discussed in this article. And you see here our dissections. Should the tumor be growing out of the tentorial edge on this side, you are getting to the ambient cistern, where is the fourth nerve, and you still have the outer layer of arachnoid as your border, as your plane of dissection. The same is true if you are going lower to the petrous apex. We are looking from below. This is a very specific technique of dissections. And you see that in the fifth, this is the 5th nerve. This is the petrous apex over here, where was the petrous apex. And this is the outer arachnoid plane, which distal to the 5th nerve is covering the nerve perfectly and making a good border of dissection. This is not true more medially and anteriorly. That the arachnoid thins out, and suddenly again the brainstem, again the 6th nerve, there is only very shallow or soft arachnoid plane, but still you can dissect in that. The same is true for CP angle, where the 7th and 8th, almost all 5th and 9th and 11th are covered by a good arachnoid plane, and if you keep out of it, you are out of troubles. And the problematic are the tumors which are going in front of the tumors, but those are not really CP angle tumors. Those are more clival and petroclival tumors. Publish the technique of dissection. So this is a famous textbook where there is discussed the supra-infra approach, and as you see the arrows, it's only for the primary region and for the lateral mesencephalon. But the most important avenue for me is this one, along the superior petrosa sinus from the side, where you can also combine. And again, the systems you are meeting, it's ambient, crural, and interpeduncular. And, actually, in this case, the tumor usually is not restricted to one single system only. The divisions between the systems, the inner layers, are only trabecules. It's not really as a wall of arachnoid. So the tumors go from cerebellopontine higher to ambient, crural, and interpeduncular system. The anterior limit is the Lilienquist membrane, as seen in this cholesteatoma. You see the posterior clinoid process. So you can use this approach for hemangioblastomas. You use it for these petrous apex meningiomas. This is after surgery. This was a lady who was 6 months pregnant, and we had a discussion with our obstetricians when to operate, so that we then operated on her when she was 6 months pregnant. You see that the plane of dissection between the vessels, this is the superior cerebral artery, this is one of the perforators, and this is the lateral mesencephalon, and you see that there is a very good plane of dissection. And at the end of surgery, you see the third nerve, here is the Lilienquist membrane, and here is the entry of the fifth nerve into the Meckel's cave, and this is the tumor origin on the anterior petrosa, of the anterior part of superior petrosa sinus. Here the obstetricians told us to quit because the kid was not doing well anymore. And this is the family, this is the kid which spent the surgery with us there. This is the mother, and here is the father who started drinking after all this. This is a schwannoma of the fifth nerve from the in a 75-year-old patient. So we didn't aim for radical surgery, just for decompression of the brain stem, which we achieved. And you see that we have left a piece behind in the Meckel's cave, which is not that easily accessible through this approach. It's not like with Cavaz's approach where you get into the Meckel's cave easily. This is not the same for supra-infra. Let's go inferior from the same approach. There are pontine cavernomas like this one. And what you need to reach is this part of tentorium. And you are directly on the cavernoma, which is located in the brain. And this is the day after. You see only the cavity. It's another one. The circle delineates the only retraction of cerebellum you need. Just a little piece, a little pushed downwards, and you can resect the cavernoma of the pons. This is after this was a little kid. Here is the pilocytic astrocytoma, which was diagnosed by biopsy, which was done elsewhere. He was given some chemotherapy, still having his upper extremity tumor. Here is the best seen the tumor. I expected that the tentorial section will be needed in this case. Surprisingly, it was not necessary. This is the cerebellum, this is the superior cerebral artery, and this is the fourth nerve. This is during the resection of the tumor. There are the perforators which must be preserved at all costs. This, when directly through the tumor, we were able to preserve the vessel. And this is at the end. This is the lateral aspect of mesencephalon where the tumor used to be, upper surface of the cerebellum, superior cerebral artery, and fourth nerve. This is the kid after the surgery, and this is the tumor cavity. I'm suspecting that there are some remnants of the tumor at the bottom of the cavity, but this is not that easily accessible. We left it behind, we followed the kid, and it's not growing, and the kid is doing perfectly well. The meningioma of CP angle or clival region, whatever you would like to call it, it doesn't matter, after surgery, and see how it's done. The cerebrum is pushed medially. Here is the surface of the tumor. As long as the surface is grainy, it's okay. This is the 7/8 nerve, so easily access the internal auditory meatus. The 6th nerve, which is well seen through this approach, you see that there is no problem to resect the tumor remnants from this region. And the only trouble was the 5th nerve, which is over there, which was most affected by the tumor. but everything went well. What I wanted to say that if the surface of the meningioma is shiny and smooth, it means that the tumor is covered by the arachnoid and you are not in a proper plane of dissection. The surface of the meningioma is rough and not shiny at all. Going superior, we can go to tentorial edge. This is the meningioma of the tentorial edge before and after surgery. And this is what it looks like. Again, you see that it's grainy and rough. Fusa is an excellent instrument put on passive mode. It means that you do not move with it and it's only sucking in the tumor. The lower part of the tumor, the surface is rough. It means that all structures are protected by the arachnoid. The upper portion of the tumor and all the structures in front of the tumor appear, and this is not due to approach cutting the tentorium, it's because this was the tumor origin. So we resected this affected tentorium and it was a great Simpson grade 1 resection. A large one, but the same way resected, no big deal about it because these tumors do grow in the, let me show you this video again, only in the lower portion of ambient cistern. And once you resect it, let's run the video until the very end, you will see that we really were only in the ambient cistern, that the arachnoid of the basal cisterns is preserved since we never really entered them. This is still the tumor resection, the passive mode of Fusa, now the tentorial section. It's not really well edited video, I'm sorry for that. And I hope that this is the case where we can see the, yes, that's it. This is the mesencephalon, and here you see that the arachnoid covering all the structures at the bottom is preserved. Never ever bypass, so we never ever were in the basal cistern. And this is the fifth nerve, which is also well covered by the arachnoid of the cerebropontine system. This is the Dendis vein, which we preserved. This is a little more or much more difficult. Meningioma is reaching the chiasm from posterior. It has a subtemporal portion. It has a portion within the clival region. So there are 4 steps. In the first step, we detach the tumor from superior petrosal sinus to devoid it of blood supply. Then we resect this part of the tumor and open the tentorium in the triangular fashion. This cut ends up just posterior to the 4th nerve entry into the cavernous sinus, and then we resect the subtemporal and interpeduncle part of the tumor. So first you see 7, 8, and ICA, then you see the 5th. Going higher, you see 5th and 6th. And 6th nerve I always look for actively because the 6th nerve palsy is a bad sequelae for the patient. Then there is the 4th, which is between the lobules of the tumor, and I admit that I still do not know how to well preserve the 4th nerve. It's so tiny, and if you need to go in front of the 4th nerve, which you always need in these tumors, it's extremely difficult to preserve it because it's so tiny and traversing the whole field. Here we see the superior cerebral artery, which is running towards us. And here it's at the end of surgery. You see the posterior clinoid process on the opposite side P2, the opposite optic tractus, and the pituitary stalk. This is the ipsilateral. No, this is the ipsilateral. This is the ipsilateral clinoid process, posterior one. This is the ipsilateral P2, the 3rd nerve running between the superior cerebral artery and posterior cerebral artery, one of the anatomical axioms. And you see the basilar artery with superior cerebral artery and posterior cerebral artery. And this shiny structure is the anterior wall of the resection. That's Lillienquist membrane. And this is the V-cut in the tentorium, which is necessary. Cutting the tentorium may be because there are quite frequently those venous lakes. It's good to know about them in advance, but we do not do angiographies anymore in these cases. So really one should be very careful cutting the tentorium because the venous bleeding may be troublesome and difficult to control. And this is after the surgery with the tumor remnant within the cavernous sinus. This is a more formidable lesion in the same area. The tumor is in the superior sinus. It's in the cavernous sinus, as seen here. It's quite large in petroclival region. The subtemporal part is also where the carotid artery is within the tumor. So we do not shoot for radical resection because we have radiosurgery. And this is how it goes. This is with endoscope now. The tentorium is already open. The big advantage of this approach is that you very soon are above and in front of the tumor and see the interface between the brainstem and the tumor. Coming from retrosec or any other approach, you must traverse the whole tumor to see this interface. This is the fifth nerve, which was really embedded with it. It runs through the tumor. I didn't see it too frequently. Going higher up and anteriorly, we reach the third nerve and the subtemporal region. That is the part of the tumor. This is the superior most aspect of the tumor, medial and anterior to the third nerve. But again, the Lillienquist membrane was the border where we finish. This is the Lillienquist membrane. This is the third nerve. This is the uncus. This is the remaining tumor at the bottom of the cavity. You see the force that I severed that. Do not know how to preserve that. Going for the subtemporal part. Then we go again for the interpeduncular system, and this is the sixth nerve. Again, I was looking for the sixth nerve very actively, not to damage it. And this is at the end of surgery, the fifth nerve being finally released from the tumor. And what we achieved by this resection is that the piece of the tumor was left in the cavernous sinus. We do not irradiate upfront, we just wait for the tumor growth, which one definitely will. This is quite recent case. So we plan on radiosurgery, but the main bulk of the tumor is away and the patient is not even aware of her fourth nerve palsy. The diplopia is there, but it's not really clinically important. There are two petroclival tumors where we were unable to find a good plane of dissection between the tumor and the brainstem, so we left this remnants behind. Both patients are perfectly symptom-free. This remnant didn't grow for 6 years, so we just follow it. This one did, so we radiated it with gamma knife, and the patient is now very stable. This is discussed in these articles. Superior, that is the last. You may read the whole medial part of the middle fossa, just cutting through the tent, and it's very straight and a very comfortable approach, which alleviates any problems with the brain retraction. You see this cholesteatoma before and after, and the cholesteatoma was resected through the supra-infra approach. Here is the cavernoma in the same region, and here is the meningioma in a young lady who came in with already apparent fatigue disturbances. We didn't want to retract the temporal lobe at all. We didn't want to touch it, actually. So we came in via supra-infra approach. Here is cutting the tentorium from medial to lateral underneath the tumor. Then the tentorium is cut in front of the tumor the same way. And here is the tumor which is directly in your view once you undercut the origin, and that was the tumor cavity. And this is after the patient is completely symptom-free, and you see that there is no craniotomy above the tumor and no damage to the temporal lobe, which was dominant in this case. Supra-infratemporal approach is good to combine with other approaches as needed. So in large tumors, we always prepare the opening that we make a short lateral cut to the sigmoid sinus to allow us to go retrosec. But you can use it for retrosec down to far lateral approach. This is a large petroclival meningioma with a very long in a vertical axis origin. This is after surgery. And you see how we did it. This is at the beginning from supra-infra. The tumor is covered by arachnoid, which is the arachnoid of cerebropontine system. This is the retrosic, and this is supra. This is far lateral. These are the 9th and 11th. And we are still on the tumor origin. And only when we release the tumor over here, the main bulk of the tumor came into view. And only then we were able to resect it. See that we are really coming in a way of far lateral, or as Juha would say, enough lateral approach. And this is the last tumor remnant. Juha, this is something I really like, your term enough lateral. I'm using it frequently. It's not only going up, but going down, but going up. For instance, this rectus sinus tumor, which is occluding the sinus, fortunately, but reaching very high up, and we want to resect the falx, we want to resect the tentorium, and we want to cut the rectus sinus, and for this you need to come from both falcotentorial roots. This is the tumor of the left side. Here we are on the right side. This was open just to have the good access to the tentorium and to the rectus sinus. Again, we are in a falcotentorial root, and we are within the sinus already. You see, decreasing the size of the tumor. Here, the resection didn't bring any forward step in surgery. Actually, I made a mistake in this case. The only deep drainage from internal cerebral veins and Rosenthal veins went backwards into the inferior sagittal sinus. This is cutting the rectus sinus, and when I cut the inferior sagittal sinus, I interrupted this deep venous drainage. There must have been some collateral because the patient survived, but the postoperative course was really, I would say, stormy, and it took some time for the patient to recover, but he now is doing perfectly well. So this is the rectus sinus with the tumor remnants within the sinus being cut. And when this is done, we are left with the tumor in the posterior fossa. So we use the supra-infra approach just to resect this bulk. Actually, this was the main bulk of the tumor. And once you resect this, which is being done now, you return back supratentorially to cut the falx. And there was where I made the mistake, just that I cut the inferior sagittal sinus. I didn't know that it's like that. This is it. This is here. We are just cutting through the falx and resecting the last remnants of the tumor, which are within the urofolds of the falx. So what we finally did was the radical resection of the tumor, and you see that we missed the falx, we missed both tentorial, and we missed the rectus sinus, and ultimately the patient is doing perfectly well. So what can we expect, or what did I achieve with this beautiful approach in 174 cases? There was good recovery in 93% of patients, 162. Minor and temporary deficits were present in 21% of cases. Those were the forced nerve palsies or some temporary diplopias, etc. Most frequently, it was the problem of oculomotor nerves. Morbidity mortality was 7%, 12 patients or 4. Let me show what it was. There were 6 PC meningiomas with a bad outcome. One recurrent pituitary adenoma, upgraded low-grade pineal tumor, ependymoma, and chordoma. Recurrent. The reasons for the bad outcome were several for technical, pure technical, when you severed the perforator or directly damaged the tissue, were in 3 cases. In 1 case, it was the venous infarction, then thalamic bleeding, which was not related to the tumor, but was related to the surgery. And then there were 7 cases which I put into the bracket of too much too late. Those are patients in their 80s the patients which have had 5 bypasses, which have high blood pressure, which have diabetes, whatever you name it, the fragile patient with a huge tumor. You cannot refuse the surgery because the patient is deteriorating, but you expect that there will be troubles, and there usually are troubles. This is one of the unfortunate cases. See the rather straightforward PC angle meningioma 3 days after surgery without any deficit and doing well. The thalamic bleeding appeared, and this was a young lady, like 57, 58. We didn't find any reason why the bleeding appeared. So to summarize the approach, there are avenues which I have shown you. What you reach is upper cerebral hemisphere, tentorium, anterior rectus sinus, pineal, and all the surrounding structure with posterior third ventricle. You reach mesencephalon, or the quadrigeminal plate and lateral sides of mesencephalon, upper fourth ventricle, posterior thalamus, upper CP angle, petrocliva, posterior clinoid area, directly accessible by supra-infra, basal, medial, occipital, and temporal lobe areas. Again, very direct and straightforward approach. In general, anything which is above the internal acoustic meatus, including the meatus, can be approached via this avenue. Then there are general management remarks. You have surgery, radiotherapy, oncological treatment. So not always surgery is needed, because the legitimate treatment protocol is observation also. So one should be very careful about the indications. The small asymptomatic meningioma in CP angle, which is not causing any symptomatology, I always follow and go for surgery. Should I prove the growth, or should the symptomatology appear? There were quite a lot of female patients in my country now. The ladies around 50, 52 are given hormonal treatment by the gynecologist just for them to be more happy and younger and better looking, which is not true. And the meningioma decompensates with that. So my first questions to patients in this age, the female ones, is always, aren't you getting any treatment by your gynecologist? And if there is a hormonal treatment, I just take it away. The symptomatology disappear and the tumor can be followed. So this is one of the things which I have learned the hard way. It's most rewarding surgery, especially meningiomas, because you are dealing with non-malignant diagnosis, and everything goes well. But it's also dangerous surgery, because patients are very frequently asymptomatic. We are getting quite a lot of asymptomatic patients. They hit their head somewhere, they have CT, the tumor is found, and they come to us. And it's always difficult to think about surgery in asymptomatic. So I offer surgery only to those where there is growth of the tumor or advancing symptoms. All the other tumors I follow. It's always remembered, is better than deficit. 2 cases of petroclival meningiomas when I left the piece on the mesencephalon are perfect proof of this. You have alternative treatment, and one shouldn't forget it. And observation is really a legitimate treatment modality. Management is the main cause of complications. But you know that you did your mistake in a management only with the hindsight. So this is something which one can hardly improve, because mistakes in management happen, that you choose surgery against radiosurgery, or in case you offer the patient radiosurgery and he could have been followed. So these management errors are unavoidable, but you do not know about them in upfront. Then there is complications which are technical or surgical, mostly the cranial nerves. Next group of complications is vascular, mostly from perforated injury. Less frequent are neural complications from the direct damage to the neural tissues. And the biggest problem in my mind are patients which I call too much, too late. unavoidable conditions for supra-infra. This is exactly what Juha has said, the training and the hours spent in the OR. This is not really the surgery or approach for neurosurgical training. This is something you really grow up to. It's not that simple and easy. So it's anatomy. After the anatomy, you need anatomy again. And if you know your anatomy well, just train and learn the anatomy again. And the physical condition for sitting position and microscope, you need to have long enough arms. Normally grown people do, but there are, of course, those microsurgeons who do not have long enough arms and who wouldn't manage. It's not only humans having petroclival meningiomas, there are dogs with the same condition you see here. The approach is not the same approach in these cases. It's enough lateral. You see the petroclival meningioma in this dog. You cannot use supra-infra because the skull base is in a right angle to the axis of the spine, and you don't get there. So it's really something like a retrosic and enough lateral approach. This is the lateral bones of this patient who has the disadvantage that the day of surgery he needs to go home and he needs to take care of his house, unlike with a human. So take home message: be flexible, be inventive, don't be dogmatic. Dogma is the most important enemy in medicine. Don't take anything as dogma. Use your creativity, use your own mind, and be really individual in relation to your patients with the help of traffic signs of the big studies. Suit the approach to the lesion, not vice versa. I don't like this term of minimal invasivity. All this minimal invasivity in general is targeted to the approach, especially in abdominal surgery. It's not, if I should have a big surgery, I would like to have a surgeon who would be minimal invasive in relation to the lesion, which I need to resect, not in relation to the skin, not in relation to my cosmetics and all these things. So minimal invasivity is somewhat dangerous term and somewhat dangerous thinking. And what I already have said, that I consider supra-infra the perineal of posterior fossa, because almost anything which is above the tentorium you can approach via perineal approach, and almost anything which is below the tentorium you can approach by this supra-infra cerebral. Just a little advertisement at the end, all about brain malformation and all about cavernomas in these two books. Juha, do I have 5 minutes to talk about the country? Just the geographical and ethnical? Sure, okay. So I'm from the Czech Republic. And since we are mostly in the east now, Czech Republic is between Poland, Germany, Austria, and Slovakia, directly in the middle of Europe.
It's no longer Czechoslovakia.
No longer Czechoslovakia. We divided in 1993, and since we divided perfectly peacefully and with no problems, we didn't get into the news. There was no civil war, no nothing. We only divided money 2-to-1. And everything 2-to-1, so it was not really an issue for newspaper and media. So the country divided peacefully. The capital is Prague, undoubtedly, and I know what I'm talking about. It is the most beautiful city in the world. You have 150 theaters in the city. You have always some concert, some exhibition, whatever you name it. A large expatriate community living there. The history is really the city where you never get bored, and you do not need bicycle. Everybody is bicycling now in Europe. Fortunately, Prague is not a flat land, so you not use bicycle in a way. We have the oldest university, founded in 1344, north of Alps. There were universities in Italy, and then Cambridge and Oxford in England. So this was the first university on the continent in 1348. Who lived there from neurosurgical point of view? It was Hans Chiari, who described this malformation There, unfortunately, the specimen disappeared because at the end of the World War II, the Germans wanted to transfer the specimen to Germany, and the train was bombed by the Allies, so the specimens of Chiari malformation is lost and not existing anymore. Then there was Purkinje with his cells. Franz Kafka was born and lived in Prague and has written all his books. There is a museum of Franz Kafka downtown. Albert Einstein lived there, and not surprisingly, one of my colleagues, a neurosurgeon from my department, is living in the same house as Albert Einstein did. Probably Albert was a little smarter than my colleague, but still they live. Wolfgang Amadeus Mozart lived in Prague here, and the Don Giovanni was first performed in Prague. There were two very famous sports people in the Czech Republic, Emil Zátopek, who won 5,000, 10,000 and marathon at Helsinki Olympics in '52. No one ever was able to repeat this, to win all three long runs. And then Vera Skáslavská, a gymnast in the '60s, who won 7 gold Olympics medals at the time when gymnastics was still done by females and not kids. There are other cities in the country which are beautiful and medieval. There are lots of castles and chateaux over there. We have lots of spa. It would nearly seem that no one is working because the spa needs clients and people there. The country is very green. It's not flat, but we do not have high mountains. But you do not find the flat land, and everything's really nice. Sports-wise, we like football, but we do not play it well. On the other hand, we love ice hockey. And Juha would know that the American football compared to ice hockey is very gentle and slow-paced sport. This is really violent and fast. National pastime, skiing. Everybody in the country is skiing. And then we have tennis. This is Ivan Lendl and Martina Navrátilová, the icons of the lawn tennis for many years. This lady was #1 on the ATP tour for several weeks. This lady, Kvitova, won Wimbledon twice, and the guy was in top 10 for nearly 10 years. Industry-wise, we have automotive is some 40% of BNP. We have this Škoda cars. You probably have seen it somewhere. It's part of the Volkswagen group. And for instance, all the mufflers for BMW and Volkswagens is produced in the Czech Republic. But we are extremely good at weapons. We were producing weapons all the time, all the history. That is why we always were occupied by the Germans. And that is also why we were not bombed by the Allies, because they want to preserve this industry. Tanks, subsonic fighters, but especially handguns. And one of the companies producing these revolvers just now bought the American Colt, which is like a cult in USA, but our company bought them. And then we have extremely good export article, which was Simtex. During the communist time, all the terrorists worldwide shopped like crazy. Now we do not sell it to everyone. Another industry is glass. This is from Reza Shah Pahlavi's palace in Tehran. All the glassware in the palace is from the Czech Republic. So we export especially to the Middle East. Avast, the antivirus company, is a Czech one. And we have these beautiful pianos which belong to one of the 3 most important piano producers. It's on par with Steinway and all these big companies. Food, very unhealthy, but very good. You know, you would get ham rolls with horseradish and cream as a starter, then type soup, which may be ugly, but it's very good. We have the typical food, which is duck leg with kraut and dumplings, followed by the extremely smelly cheese. You can eat it alone. You cannot eat it in a company, followed by crepes with some food, so that's okay. But ultimately, the best in the country are not these girls, and we have plenty of beautiful girls in the country. No one else does, but the beer. And it's Pilsner Urquell, which is produced in Pilsen. That is why all beer world around is called Pils. it's because of Pilsen. But there's no beer which can be compared to this one. This is still the best, and whoever has the possibility, buy it in your shop. It's exported worldwide, and you will realize and recognize that it's really the best beer. Thank you for your attention, and thank you for listening to my patriotic expose.
Okay, very good. Okay, Juha?
Let me be. Okay, it was, dear Vlad, it was really wonderful lecture.
Thank you.
Good surgery, good thinking, good anatomical knowledge. My teacher in anatomy in Zurich in 1968 or 9, late Professor Giant Thunder, said, medical study is a lifelong study, and anatomy even more. So we will never be good enough in that, but you seem to master much more than many others. And like you said, this approach is not easy, but with good anatomical and surgical skills, you can do it and have extremely good results, like you showed. So the discussion is open. Please go ahead. I saw there are some questions in chat. Can you?
I have a question.
Of course, Ibrahim, go ahead.
Thank you. Thank you, Juha. Thank you, Vladimir. How nice to listen to your
Hi, Ibrahim.
Beautiful lecture. I really enjoyed every minute. You hosted that so many times in Prague on conferences and so on. And you were a very good host for all of us. I remember that very vividly. And I remember going in a river journey over the river, Charles River. You took us on a journey. And I remember standing there on the Charles Bridge and looking to the other side to see Franz Kafka, where he used to write his novels. I do remember vividly when Czech Republic won the ice hockey championship. It was a great celebration in Prague. I just want you to answer me on two questions. First one is I know that your father was a neurosurgeon, yes? Can you tell us more about what did you learn from him? And the second question, that when you open the tentorium from below, can you tell us where do you like to open and in which direction? Thank you very much.
Once again, about Ibrahim, about
you open the tent. When you open the tent from below, where exactly do you open it and which direction? Do you go towards the hiatus or do you go anterior or posterior and so on? So what are the intricacies of this?
Okay, thanks for enjoying Prague. That's first. My father, he was born in 1921. Then the Germans closed the universities during the war, so he studied the medicine after the World War II. And he started his practice in 49, and he was whole life in neurosurgery. And he was the first generation of neurosurgeons without CT, with only clinical symptoms and some ventriculographies and like that. Still, I have learned from him nothing from technical point of view, but all from his philosophy and thinking, to be thoughtful about the indications, to evaluate the patient. He was at the end, not at the end of his life, but later in the life, he got interested in the quality of life assessment. He even published an article and even has given quite a lot of lectures on this topic. And that was really something which I have learned from him, that in the result, the quality of life is the most important parameter. At the beginning of his career, they just divided it into survived, didn't survive. That's not enough. You see that we are combining mortality plus morbidity. And morbidity is probably more important than the mortality. And we are going even further, and that's probably his heritage, that we are evaluating the psychological functions as well. You know, we do not just evaluate hemiparesis or diplopia or something like that, but what the patient is able to perform, whether he is able to get back into his activities the same way as before. So we are looking for really minor things. I would say that we are going as deep as possible. And then there is probably the next step, which again would be my father's thinking, but my son's job. Whether we fulfill what the patient expects from us. If I will make it simple, it's a supranuclear hemorrhage bleeding patient. He comes to us with headache. He expects us to treat his headache. This is not what we do. We just do him a hole into the skull, we clip his aneurysm, but we do not help him with his headache. And we should be thinking about whether we really meet the patient expectations. All right? And now let's go for tentorium. I opened the tentorium first from posterior to anterior in the direction of pineal region, just to be lateral to the rectus sinus. If I open it totally, you know, not always you need it. A small triangle is usually sufficient. And then I only go laterally to the petrosal sinus. In most of the meningioma patients, you can sacrifice the sinus because it's already occluded. It's a tiny sinus which the tumor occludes very, very, very early on. And then I kept along the petrosal sinus, if needed, as far as the fourth nerve entry into the skull. And sometimes you need to remove it. Sometimes you may just fold it and leave it behind and no reconstruction at all.
Thank you.
You're welcome.
Harshad, you have a couple of questions?
I see that if I coagulate the dandy vein, if the tumor occludes petrosal sinus, they are sure coagulated, but usually I don't. Exoscope superior to microscope. Yes, it is. I think it's future. I think it's really future. The vision you have is the deeper field, larger field. You have one more extra step in magnification, which sometimes is very helpful. And then what's probably the most important feature of exoscope is its teaching potential. Every observer has his glasses and sees exactly the same thing as I do. This is not the case with the microscopes and with all the screens. This is really excellent teaching. And if it will replace microscope, I guess it will. I guess it will, that it will improve in a way that it will, and it's really a future. It's not the huge bulk of the microscope in front of you, but some heads-up display where you will have the same image as you have in your exoscope now, and you will have it directly in front of you. So I believe in it. Should I go ahead with the questions there, John, Juha, from Cat?
Well, whatever you want to do, Juha.
Whatever, or we can have oral questions if there are some.
There's a couple of questions. There's a couple of questions by Harshad. Do you want to ask those questions? You had a couple.
Yeah, there is. If I use ultrasound for small tumors, I don't like ultrasound at all. I still think that it's raining, the image. That's it for the questions. Thanks for greetings.
Oh, okay. Okay.
Thank you, Professor Vladimir. I'm Dr. Harshad Parekh. Thank you for answering my questions. I have heard you so many times, and you have always pearls of wisdom to give us. And wonderful. And I enjoyed all the approaches what you have described. And you are very simple in your techniques and giving all the tips. Very easy to understand how you go and how you follow. And one more thing, good thing today you said about all the cases does not need to be operated. Small meningiomas needs to be followed up. And I've seen many people presenting with the small tumors, which we excised and agreed with. We should observe them and see whether they become symptomatic or increase in the size. Wonderful, wonderful. And of course, beautiful country you live in. Amazing. Love to visit once. Thank you. Wonderful.
Thank you. Thank you. I believe in observation. I really wouldn't operate on an acoustic schwannoma if the patient is... I had a patient whom I seen when the lady was 50 years in 1997. She had a small acoustic schwannoma. Her hearing was perfectly well. She was using phone for the hearing, and she was working in the state opera. So simple seventh nerve palsy was no go for her. 10 years later, without any surgery, she got deaf on the opposite side ear. Now she's 76. It's 25 years long. The tumor is half the size as at the beginning. She's still phoning with the same affected ear, and she's happy. No surgery at all. And these are the, actually, Juha, you probably wouldn't agree with that, but from your philosophy, I have learned the simplicity. Your term enough lateral approach is excellent because it's exactly what we are doing. We are not doing dogmatically the same approach one as the other. You tailor the far lateral approach to the lesion. The same work you can do from above the condyle and from below the condyle. So why resecting it? So this is something I really enjoy, and what probably led me to being simple and expressive. And the anatomy led me to arachnoid membrane now, because I believe that in meningioma surgery, it's a paramount structure.
Absolutely, and this small acoustics with a hearing preserved is really a challenge for all surgeons, according to me. And suppose that by chance the patient loses the hearing, even you may have preserved the seventh, then the tumor may not have grown further, as you have rightly said about. We have seen in many cases, and especially, and we feel guilty of it, to making them deaf by operating on that. Maybe we are going to, and we have a competition around the country. Why are you not? I will operate this case and remove this tumor. And this was something worth learning for all of us. When not to operate and when to operate. That's very important. Very important.
Yeah, that is the major difference between my father and myself. My father, in his armamentarium, was surgery only. There was no other option. We now have multimodality. You know, we have endovascular, we have radiosurgery, we have observation, and we have surgery. And since we needed to compete with this alternative treatment, we improved tremendously. In large petroclival meningioma 25 years ago, if you said this is not operable, no one would blame you. Now we do that.
Correct.
On the other hand, I always loved basal tip aneurysms. But now I'm afraid of them, because just putting the clip on, dissecting the aneurysm, I still have in the back of my mind that there is endovascular treatment possible. You know, so you really must be good, must be better. Otherwise, we wouldn't have the raison d'être. We wouldn't survive. And we are better. We can admit it that we still are better than any endovascular or any radiosurgical treatment.
Correct. I agree with you. Wonderful. Beautiful country. Once again,
it is. I'm happy.
Very nice of. It is very nice of you to show us.
You wouldn't like the weather now. It's cold, raining, dark.
Yeah. Wonderful, beautiful. Thank you.
Thank you.
I really liked your presentation very much. The philosophy, my philosophy has been simple, fast, preserve normal anatomy. 3 words.
Right.
3 words. Simple things. Surgery should be simple, not because of the small openings, but at the goal we should do well, and this is important. My question is, usually this is always discussed about the sitting position. Did you have any resistance with your anesthetist to begin the sitting position?
No. We were always doing it, so there was no problem with them, and they really are good with that. They are now using this echo, and they see like a rain falling down, and they see the bubbles there. And they really know when to act, but it's so seldom that they need to act and do something that we are careful with the craniotomy not to open any sinuses. We lift the legs, so we are really happy, and the anesthesiologists don't complain. Ibrahim?
Yes, Vladimir. I see myself in the same position that you were as a youngster. I am a father of a daughter of mine who is to become a neurosurgeon within a couple of months. So she will finish her exams and she will be the first female neurosurgeon in Jordan. If you were in my shoes, what would you tell her to do?
difficult to say. My father never told me go and study medicine and neurosurgery. I never told my son, but it was you know, no other choice. So I wouldn't tell her anything. I would let it up to her. Otherwise, she could blame you.
She's already
neurosurgeon. So she should find her subspecialty, which in female decision, probably the best would be the pediatric neurosurgery, which is obvious for females, and they are good at it, and they really are much more emphatic than we are. So I would tell her to go for pediatric neurosurgery. So she would be not only first neurosurgeon in Jordan, she would be the first pediatric neurosurgeon as well.
Sure.
Don't tell her, let her decide for herself.
Sure. Thank you.
Yeah, welcome.
My teacher, late Professor Drake, said more than 30 years ago, girls are not good for neurosurgery, but I didn't believe. I have trained many, and many became very good ones. So it doesn't depend on the gender. When Dr. Pieles was speaking in the memorial of Dr. Drake, he said the most important thing to become a good neurosurgeon is to select a good wife, or nowadays husband, of course. After that comes everything else, hard working and anatomy learning.
You remember well when we were young, the neurosurgical congresses were all male events. There was not a single female. Now, when I'm getting a new resident, I actually prefer girls against the boys, because girls are more responsible. They don't do any, easing up. They do their work perfectly. The other problem is that there is something like a ceiling of risk willing taking, and girls being more empathic than we are, they have this ceiling lower than we do. So they are, since they are more responsible, they are less prone to take real big risk.
So we have changed in 30-40 years our thoughts very much, and in good direction, so. I think in good direction. I totally agree.
Yeah, definitely. We are the specialty is going to survive without any problems in future. No problems, I foresee. The thing is that we should keep under our umbrella all the neuro things. In my hospital, we have Institute of Clinical Neurodisciplines, which I'm chairing. There's spinal unit, that's endovascular treatment, that's stroke unit, that's neurology, that's neurosurgery. Everything together. The same team is taking care of this. We are doing carotids on the neck. It's a neurosurgical procedure, because the procedure is done because of the brain, not because of the vessel, like the vascular surgeons take it. So we try to keep it all under our umbrella. If it's divided, like in France, endovascular, and you know it well, Juha, that the endovascular people do not talk to neurosurgeons, it's completely wrong. It's completely wrong. If the radiosurgery is a self-standing department in the same hospital as the neurosurgical department, they don't talk to each other. Where are we? So we really should keep everything under an umbrella. And then the neurosurgeon is the best suited to do that. Because we are surgeons, we are much more aggressive, we are more, let's say, self-oriented or whatever. We know how to end the discussion. So it works this way.
I would like to ask Subin to comment, because I know in Hwasan, his hospital, one of the largest neurosurgical centers, he has all the facilities in the same, everything in the same house. So how are you dealing, and what are your thoughts, Subin?
Yes, this approach we also very commonly use, but normally we don't use the sitting position. Thank you, Professor Bennett. And tonight there's 1,700 audience
Good.
watching you.
How
Yeah,
much?
in the WeChat channel.
How much?
1,700.
And
that's
during the
great.
weekend, more is coming. During the weekend, more is coming. Usually
Yeah.
it is twice.
Yeah,
after
yeah,
the
yeah,
weekend.
yeah.
Because now it is Friday evening here, so the many neurosurgeons want to spend time with the family and so after the week. So they take a look then during the weekend. So it was wonderful lecture. I think we enjoyed all, and it remains in our memories very well. And Prague is wonderful city. So if you have a possibility to go to Europe, go to Prague. There are many big cities, good cities in Europe, but Prague is one of the best. People are nice, polite, and you can enjoy life everywhere, even the Pilsen. I
Thank
don't
you,
know
Juha.
if you can buy Prager Pilsen here in China. Maybe in Shanghai you can do it. You know what I'm talking. Subin?
I don't know where can I buy
You don't know
the
Czech
beer.
beer?
Yeah, but I enjoy the beer in Prague. Yeah, yeah. It's fantastic. Very beautiful city. And I take maybe 2,000 pictures in
Wow.
Prague. Very
Wow.
beautiful city. Yeah.
It is. Thank you.
Okay, I think we can close now. So next week will be my and Subin's last webinar. I will speak about my more than 3 years neurosurgical experience in China. So I will try to make the same level presentation as flat if it is possible for me, but I will work hard for that. So welcome next Friday the same time to join, and I will tell how it has been here.
Okay, very good. Juha, let me just show an event we have tomorrow that you may be interested in, Juha. This is the idea of Sarath, a neurosurgeon from Sri Lanka. He's going to have a discussion with an American neurosurgeon about the different ways things are treated in a third world country compared to America. And that'll be about the same time tomorrow. Okay, thank you everyone for coming.
Thank you.
See you
Thank
next
you.
week.
Thank you.
Bye.
Bye-bye.
Have a good day.
Bye-bye.
Bye. Thank
Bye-bye.
you.
Thank
Bye.
you. Thank you. Excellent. Excellent. Thank you.
Thank
Bye-bye.
you.
Bye-bye.
Thank